And welcome to Module 4 of the Vocational Rehabilitation Foundation series. We're going to look at VR interventions briefly on this one and just share a case study at the end. So session aims are to just quickly review the three-level model approach, think of those considerations when undertaking VR, interventions at each level of the triangle, and how could we adopt in our own practice, and then just having a quick look at a case study. So very quick recap. So we were just thinking level 3 at the bottom is advice and signposting, anyone who's employment education, and that's all stroke services and third sector. Middle one, level 2, so that's return to work service. So that might be your ESD, community stroke teams, but not limited to that. It might well be that you're doing some level 2 as an inpatient as well. They need targeted rehab perhaps to support further return to work, and that's those specialist local services. So that would be any stroke rehab team, even your acute stroke teams as well, if required. And then that specialist level at the top, that's kind of that regional service that we're not directly commissioned for in our network. So I just asked kind of the network when we did this training live last week what interventions they think they're already doing. So again, if you want to pause your video and have a little think, or just jot some ideas down. And this is what they said that they were already doing. So a lot of signposting, fatigue management, driving support, job analyses. That actual rehab for VOT rehab, health and work reports, supporting letters, disclosure. There's lots of ideas there that are already happening, which is brilliant. So this is just to kind of confirm that staying in work can be seen as a key outcome in rehab. And those early conversations can be really powerful. We want to make sure we're educating, providing information, we're working jointly and holistically as an MDT. Empathy in those situations, how important the goal setting is, which we discussed in Module 3. Self-management and taking an active process, and having that support network, those pink flags that we talked about again in Module 3. So just a really brief review of health and social care professionals that kind of work at stroke survivors. So I think these are from the guidelines. There's a resource there that can support, I think it's a document from the government, work conversations in healthcare. It's just talking about encouraging that contact and that disclosure as much as they are willing to disclose. So I just wanted to put some kind of considerations or where you would think about signposting to. And Module 5 is going to be more practical session about some tips of who's out there to signpost to. But there's that legal and financial support at that stage that might be providing information about benefits. I've put citizens' advice because that's generally the kind of national one, but there are local charities that are able to provide that support as well. And then there's those kind of brain injury specific charities like the Stroke Association, Headway, Brain Charity. Thinking about those self-management techniques and looking at potentially fatigue, anxiety management, that sort of thing. Shared the personal stroke record as well with the group. We did the training. Work is an element of that, and it sort of talks about kind of what matters to the person and helps kind of be that holistic approach to stroke rehab. Signposting to occupational health when that's necessary. And then you're thinking about your onward referral. So if you are an inpatient setting, you're referring to community services, or you're a community service referring on to a specialist service. It's just thinking about giving some more information to prove that you've maybe had those conversations early. Thinking about referring on to psychological support if it's available, stroke specific, or it might be charity support, talking therapies within the NHS as well, or privately if that's something that they can access. Making sure that they're involved in a 6-month review, that's always useful, especially if they're a worker or they potentially might have issues down the line, because we want to consider those maybe with milder deficits that might only be in hospital for a few days that kind of could fall through the net. and then have difficulties down the line returning to work. And it's working out who you would signpost to contact if there are problems down the line, working out who the best person or best part of your service is to provide that information to them. So we think about that middle level. So obviously I've put recommended MDT approach is all an MDT approach, but it's thinking about responding in a timely manner, hopefully able to return within 6 months. And I think these are the key considerations that I wanted to put, was kind of, you're there to facilitate rehab goals and signpost on. So you're doing the actual rehabilitation of the stroke rehab, but if there's anything more specialist, you can signpost that on. You're not there to decide whether they can return to work or not. That's between the person and the employer. You're there to support the rehab side of things and make recommendations and goals in terms of their rehabilitation. Disclosure conversations early on, and there was a question in the last group about, which I did mention in module 3, about the patient can disclose as much or as little as they want, and you as the professional you're not the one that's disclosed that information. It's down to the individual, the patient, to disclose that. Any reports or fit notes should go to the individual themselves, not directly to the employer. So you would never do a report and then email it to the employer unless you've got a situation where your individual consents, and you would then obviously CC them in an email. It depends on what you're able to provide in your organisation, whether you are able to email patients. But I think the safest way is usually give it to the patient, and then they can decide what they want to do with it, who they want to share it with. Trying to provide that, encourage that individual to take responsibility and be as independent as possible with you to guide and support. And joining a local or regional network for clinicians working in VR, if that's something that you do. I know the RCOT have one, or the Vocational Rehab Association, or there's a national NHS Neuro VOC Rehab network as well. So I think thinking about those initial assessments using a biopsychosocial approach, so thinking about their medical history, work, any functional and cognitive assessments that you've done, and then considering what they've got already from a work support environment, social, what barriers or obstacles that you might be able to identify, and what are their key drivers or key worries about going back to work. Thinking of doing job demand analysis. I've sent some templates around last week, but you give me a shout if you don't have access to them. I can send them on. Trying to liaise with the employer if that's something that you're able to do within your remit of your service. Again, considering patient consent and disclosure. Usually it would be trying to set up something that's a joint discussion. If you can't go face to face, whether you're able to do that through Teams. Looking at work readiness and those goals in MDT. The case study that we'll come on to is thinking about how you can get their skills up to scratch for going back to work in terms of hardening and readiness. We've already said about report writing, using their AHP Health and Work report, which is accessible to download. And that might be for the individual to take to their occupational health sessions, or for the employer for the reasonable adjustments. You might be planning and supporting with adaptations, altered hours duties, maybe going and doing a workplace assessment if you're able to manage that. And then we've said about access to work in module 3. Thinking about supported exit, that might become longer than the 6-month pathway, and it might be that they need to be referred on, but it's just maybe having those conversations initially. It might be ill health retirement or those sorts of things. Driving for work, so kind of supported with the driving pathway, and then thinking about what frequency of review. You might find at this point they're not really on like an ESD type pathway, and you might not need to be seeing them as often, but obviously that depends on your service remit. And then I know that we've been through the specialist stuff already in the first couple of modules, so I won't go on too much about this. But there's those key points up there that you can have a little look at. There, it's more those complex factors and employer difficult complex impairments. and then they're the interventions that we would provide at level 1. So obviously there is that link with supported exit from work. It's just if it takes longer, you might start the conversations and considering it at level 2, but then if they need more, that would be where you would need that specialist intervention service. Okay, so I just wanted to mostly go through a case study. This module was always going to be quite short, so I just wanted to provide you with a case study. So it's Chris, who is 46 years old. So he had a cardioembolic stroke because of an infective endocarditis diagnosis. So he was on like longer term antibiotics at home once he was discharged with a PIT line, and had a nursing team coming out and doing that for him. So because of the nature of the stroke, he had kind of scattered infarcts. So he had quite a few different changes. So on discharge, this is what he had. So he had upper limb weakness, cognitive changes, attention and processing mostly. That was impacted by fatigue. He also had kind of physical fatigue, bit of an inattention, mood changes and changes to his insight. His insight was more around the fact that he was so passionate and driven that he almost was in denial, and having insight into that at the start was quite tricky to get him to understand and be realistic. So his pathway, I think he was 3 or 4 weeks on acute stroke unit just while he was being managed from a cardiology point of view, and then he had 2 to 3 weeks at inpatient rehab. And then he had the full 12-week ESD pathway, and then was put on the OT outpatient pathway, which was up to 6 months. So he was able to be offered quite a significant rehab, access to rehab, which was really good in the team that I worked in at this time. So he lived with his wife and 2 children, and he was the main earner for the family. And in terms of employment, he was a business owner with his friend and business partner. He was a chef, but also a caterer for local businesses. So he provided it across 3 different businesses, but also did private events. So he cooked for, he did weddings, parties. He might, sometimes it was people who had dinner parties on a Friday night would go into those big luxurious houses to do that. And it wasn't uncommon for him to work 60, 70 hours a week. Sometimes he wasn't just doing the cooking, it was the financial side of the company, the designing the menus, sourcing the ingredients, providing invoices, with quite a lot gone into it. So yeah, it was I would say stressful to a point where it was demanding on his time, but it was his passion as well, so he absolutely loved it. So these were the things I just wanted you to consider in terms of the case study. So think about the barriers and facilitators and motivations to return to work, what potential flags were involved, and his impact on recovery and well-being, and any VR interventions that you might think would be required. So you might just want to pause your video and have a little go at that, and then I'll bring up some of the ideas that were on the call last week. Some ideas that had come from the group, and there was loads of really good responses, so I'll just pop them up, but you can have a read through them. But most of the ones we're looking at kind of barriers were around his fatigue, his cognition, limited HR policy, that he's passionate, he's the main breadwinner, and it's his friend and his business owner, and that could, I guess, be a good or a bad thing, but for him it was a good thing because his friend was very supportive. And it was very important for the business partner to understand limitations, flexibility in terms of being able to return to work. I think that was, for him, it meant that he was able to kind of set his own timescales, and they shut down half of their business that the business partner could he just had the part that he could manage on his own, and then as Chris was able to increase his abilities, then they were able to access more, and to start with he kind of started doing the menu designs and that sort of thing, and that was part of his cognitive rehab that we did. We did upper limb rehab, yeah, in relation to his workplace activities. Obviously, being a chef, he needed both arms and to have quite high skill in his chopping. The cognitive side of things was around like his attention and focus in terms of like a busy environment. Other things as well was kind of his finances as well. Like that was something that we're just finding a little bit more tricky to start with. On to the next page, again, very similar about fatigue, financial problems, functional ability. Driving was mentioned as well. You know, he had a work van to get to work, that sort of thing, like picking up all his ingredients. Income protection or business insurance, considering that around his finances, and being able to disclose with the business partner what he was able to do. Another good one. With his fatigue management to start with, he couldn't manage kind of his full days, and obviously the 60 hours was a no-go. So we had to look at maybe doing a few hours a day on non-consecutive days and just build that back up. There's quite a lot of psychological aspects as well. Kind of his fear of medical setback with the nature of the stroke in the first place. He was only 46, and it came out of kind of nowhere with the endocarditis. So he was quite anxious about from a health point of view, but also he was very anxious to meet his customer demands. He had big events coming up that I think he had to let one person down, but other than that they managed to pull it out the bag. But the financial pressure as well was causing quite a lot of strain, paying bills, rent, supporting his children. This next one, some of them are duplicated, but yeah, it's that safety awareness, health and safety, kitchen practice, thinking about his complete picture as a role, and a job demand analysis was really important for this chap because there were so many aspects of the role. It was literally like every skill you could think of we had to work through. So yeah, it was a really good case study, and he ended up making an excellent recovery. And it was a full MDT approach for this chap, and he went back to work and vowed he would not be doing 60-hour weeks. And I think they ended up hiring someone to support with their private events in terms of kind of like the client facing, managing the invoices, and designing the menus and that sort of thing. So it kind of put a bit of perspective for him in the whole thing, which I thought was really good. So then I'd just said about main learning from today. So there's a few ideas there and some references. And again, if there's any questions, you can always drop me an email. That's great. Thank you very much for attending.